Hi, this is
Good
Ramona.
morning. Good morning. This is Gail.
I will say this that we'll go through it in a minute, but just so you know, we're going to do some polling um, a little bit later, and you'll be able to poll if you're online and you're at your computer. You can go to poll.ev/North Central 418. If you want to do on your mobile, you can just type in 3 as the number and North Central 418 to join the group, and then you'll just have to type your answer into the send line. So if you guys want to do that, we'll have a slide on it. It just says North is pollev.com/North Central 418. Sorry, pollev. E is an echo, V is a Victor, /North Central 418. And if you're using it is in your, you're right, it is on, I don't know what page number it would be, but it's in your slide. Oh, I
someone to test again?
Can you hear me?
Oh, I can hear you, Molly.
I was just trying to be like a rock star.
All right, let's try to do, I feel like I'm in an echo. Is it me or is it? It's echoey in here. Still working on audio. I see someone's trying to talk from 2300, last 4 digits of a phone number, but not hearing you. How about now? I turned my microphone off because it's echoey. Can you hear now?
Yes.
Thank you.
So we'll have to have the echo or nothing.
We'll try it.
So I'm seeing that we have Melina Stott on the phone.
I'm here, Wendy.
Oh, and Jorge is here. Oh, well, maybe everyone can hear now. So can everyone on the phone say their name for us, please?
This is Lisa Apple with OBHC.
Morning, Lisa.
Carlson, Land Clinic.
Morning, Gail.
Good morning, Melina.
Loretta Stover, the Center for Alcohol and Drug Treatment.
Good morning, Loretta.
Good morning, Melina Stott from AmeriGroup.
Morning, Melina.
Christina Harville, Columbia Basin Family Medicine.
Good morning, Christina.
Amelia Davis with Coordinated Care.
Good morning, Amelia.
Tracy Miller, Mid-Valley Clinic.
Good morning.
Roger Chauffier, the consulting team.
Good morning, Roger. And I saw that Becky was trying to talk, but I didn't hear her. So Becky Corson from Mid-Valley.
Clinic Administrator. Thank you.
Good morning, Becky.
Molly Morris, Cooley Medical Center.
Molly.
Anyone
Heather
else?
Massart,
Moses Lake Community Health Center.
Good morning, Heather.
Hi, this is Shoshana Palmentier, Cooley Medical Center.
Good morning, Shoshana.
Ramona Hicks, Cooley Medical Center.
Good morning, Ramona. Anyone else?
Darla Boothman, Grant Integrated Services.
Good morning, Darla. Anyone else? All right, let's go ahead and look at the agenda. Once you've had a chance to look at it, if I can have a motion to approve.
Looks full. This is Deb. I'll move to approve.
Thanks, Deb. Do I have a second? Thanks. All in favor?
Aye.
Any opposed? Thank you very much. Now let's look at the minutes. It's been a while since the November meeting. Thank you, Paul. And a second? Thanks, Tessa. All in favor?
Aye.
Aye.
All opposed? Alrighty. So just moving on, don't forget your microphones. I am echoey, so I keep turning mine off and on. So if those on the line, if I forget to turn it on, please tell me. I'm just trying to reduce some of the feedback in our room. The members of the learning community have been fully funded through 2020. I wanted to let you know that the MOUs were distributed. Most have been returned. A few have asked for extensions, and so and that's fine. If we haven't communicated, please get those MOUs. If you need more time, please let John know. John's been sending those out. There have been a few additions, changes within the MOU, so please take a look at those on the deliverables. We've outlined it. We're a little more structured in what we put in there as far as the deliverables. The only thing that changed as far as what we've asked of you is for every organization to present at least one QI effort that's related to their change plan at a WPCC meeting or the symposium. So that's in there. That's really the only change. But take a look at that because we did tie funding to each deliverable. If you don't receive the MOU and you want to take a look at it, let me know and I can forward it to you for your organization. If you're participating in the Population Health Plan, our next meeting is tomorrow. Thank you for all those who got the homework in over the holidays. I know that was a challenge. And we have our, I forgot to put it in here, but our Q4 reporting, we pushed that out till the 10th so people didn't stress over the holidays. There were several that were really stressed. And I heard from a few that they'd be taking it home, and I didn't want that. I'd rather you be home with your families versus working on a Q4 report. And so we stretched it to the 10th. The caveat with that is once the 10th comes, there's no extensions unless we really, really have to. It takes a lot to get it back open, but that's when it like really closes. So please have your Q4 report, that at least the progress to date part in by the 10th. Any questions? Okay, just to remind you, I think I've sent this out on the email. There's a buprenorphine waiver training coming up on February 7. It's led by, I took that out. I guess I took it out. I had the flyer, sorry. It's head by a Confluence Health physician. Sorry, I took the flyer out. But it's on the 7th. It's here at Confluence Technology Center from 9 to 1. If you need more information, let us know. There's the registration link there if you have any providers who want to be a MAT waiver trained provider. There's 4 hours in person and then the additional 4 hours online that they have to do to get that done. I'll send that flyer out again. So here's our first polling that I was talking about. If you haven't done so and you want to use your mobile phone, you can text to the number 22333, that North Central 418, and that'll enable you to join our group. If you're online and you're using your computer, you can go to pollev.com/North Central 418. Or if you want to download the app, you can, but that's not necessary. So for our first question, I've heard from several individuals that the Monday meeting, people wanted it changed to a different day, different time, or other variation. So I just want to see where we're all at, get the pulse of the group, and go from there. So far, we have 67% that like this date and time. Results still coming in. All right. Give it 30 more seconds. Unless someone needs more time, just tell me if you need more time. Okay, I'm gonna lock it. 80% want to keep it at this Mondays at 11 a.m. So that settles a big question for me because I keep hearing from individuals. So now we know this is the will of the group. Any updates from partners on the phone or in the room that they would like to give?
This is Mike Lopez with Grand Integrated Services. Darla, I didn't realize you were on the phone, so apologize, but just wanted to let everybody know that Gail Goodwin is no longer with our agency as of, I believe, the 31st. So.
Thanks, Mike. Any other announcements, projects, grants?
Tessa from Confluence. Just wanted to give the update that we are starting our UW Primera AIMS grant. That starts this week, 15 months. So it's a rural mental health initiative, integration initiative. We're also doing the BREE Collaborative. So that's an 18-month commitment that Dr. Fried signed us up for. So that starts this month as well. And like I said, for 18 months, we'll look to do that in a different department. We're going to do the rural mental health integration in our OMAC clinic. And then we're also partnering with AmeriGroup to start the ESPER. So we got a lot going on in the next several months for Confluence for behavioral health.
That's great. Cooley Medical also got the UW AIMS. I'm assuming you guys are starting this week also, Shoshana? I know I put her on the spot.
Actually, next week is our kickoff call with the UW AIMS Center, and also our psychiatrist, Dr. Marilyn Holman. She starts tomorrow here at Cooley Medical Center.
Great.
This is Tracy at Mid-Valley Clinic, and we have Leslie Height, a psychiatric nurse practitioner who has joined us. She started October 14th, and she's actively seeing patients. So we're pretty happy that we have her on board to do our collaborative visits and primary health, behavioral health visits as well.
That's great. So Cooley Medical Center has a new psychiatrist adult, and so does Mid-Valley. Deb?
So I wanted to talk a little bit. Our organization on Saturday participated in an event called Elevate Recovery, sponsored by Washington Recovery Alliance. I personally was present. I was happy to say that one of our health home clients was present. There were 18 plus community members present at this event who are people in long-term recovery from substance use disorder addiction, and the trainers are the two particular trainers that were here for this training. There were 5 of them, or there will be 5 total in the state. These 2 trainers were from Passages, a community-based organization in Spokane, and they're both peer specialists. They trained the group, it was from 10 till 4. They trained the group on how to succinctly tell your story of recovery. How does the government process work and how does decision-making work? How do you talk to your legislators and tell them what you need for yourself for changes and improvement in services? An East Wenatchee City Council member was present in the morning to present as a council member what are the things he would like to hear. Representative Mike Steele was there in the afternoon to talk from the state perspective. It was an amazing, empowering, life-changing experience. And I'm excited because our client is to the point that they want to start sharing their story. So it was a great opportunity for me as an organization leader and to be able to empower the voice of our client. It's very exciting. And so there is a group of people from Wenatchee that will be attending, and anyone is welcome. It's still open. On February 5th is Recovery Advocacy Day called RAD Day at Olympia. I attended last year. There were over 450 people in long-term recovery that joined together, and they were scheduled with appointments to meet with their representatives and tell their story. It's very empowering. Last year, the 4 bills that were advocated on all passed unanimously. Every single one.
Nice.
So it was really an opportunity to show me, as well as community members, the power of the community voice. So I am motivated to do more things like that this next year. How do we empower the voice of our community?
Thanks, Deb. That also talks about what we do within the learning community of the power of the patient's voice in quality improvement. If your last 4 digits are 7100, can you please mute yourself? Anyone else? Any updates they want to share?
So I'll share that since our last meeting, 2 of our CVCH providers, Dr. Jerry Crawford, our pediatric medical director, excuse the microphone issue, as well as Abby Shepard, one of our behavioral medicine providers, both completed the Center for Excellence training for evaluation and diagnosis of autism in November.
What does that mean for your organization?
It simply means that they've completed that training.
Are you able, I guess, I'm sorry. Are you able to offer more services, or are you able to do with the autism?
Well, it means that they're uniquely qualified for evaluation and diagnosis of autism. Yeah.
Have you been able to do that?
We've had we've been very limited in our region for Center of Excellence providers. I don't know if anyone else, at one point we had 4 or 5. I don't know. One of them retired a couple Decembers ago, and anyway, it's a good thing.
Great. Thank you. Yeah, turn your mic on, please.
This is David Olson with CVCH. On December 17, a group of community leaders met with representatives from the Blue Zone Project, and the Blue Zone Project has formally indicated that they think that the Wenatchee Valley communities would be an excellent addition to their network of communities throughout the United States that are working to improve the health and wellness of their communities. CVCH has agreed to contribute $200,000 a year for 4 years towards the cost that it would take to implement this program. 200,000 down, 1.1 or 1.2 million to go. A local citizen has agreed to match CVCH, and our hope is that other organizations, including some major employers, will join us. The city of Wenatchee has agreed to make a commitment as well. I think this is, when we talk about social determinants of health. So I think assuming that we get sufficient sponsorship, this will have some very good effects on the community. Their recommendation is to start in the Wenatchee Valley itself, but the intent is eventually to have this go beyond just this area.
Great. It's definitely very upstream thinking, upstream way of doing things.
Center will be offering its second motivational interviewing training starting both Fridays, this Friday the 10th and next Friday the 17th, and it's being held at Parkside.
Okay. Do you have openings for individuals?
Nope.
Okay.
Just thought I'd announce until you top.
Anyone else? A lot of good things going on in our region. Okay. I'm going to back up. Some questions were and statements were made at our November meeting. And I just, for the sake, just want to talk about the evolution of the Whole Person Care Collaborative so that we're all on the same page. I really took to heart a lot of the comments that were made and really looking at it as a quality improvement of how we can improve the way we're doing things so that it's the most productive, most valuable for those who are participating. And so just to back up, we'll talk about the timeline, and that's in your packet. Back in 2015 is when partners and stakeholders started meeting. We had some SIM funding, and it's kind of the initial seed for the NCACH. In 2016 is when we were officially designated as an ACH, and there were two work groups that were formed, Optimizing Primary Care and an Obesity work group that were meeting. The Optimizing Primary Care was obviously very primary care centric, and it was actually the seed that started the Whole Person Care Collaborative. So their main focus was behavioral health integration, whole person care, and patient-centered medical home. We were under the SIM funding, and that's probably what was more primary care centric. In 2017, a Medicaid demonstration project, which is what it was initially called, it's now called the Medicaid Transformation Project. We received the funding. That was the year one for that. It's when we knew the FIMC was coming. Behavioral health organizations were folded into that Optimizing Primary Care work group, and it was then rebranded as Whole Person Care Collaborative. So there was a slight shift from being primary care centric to include behavioral health as well, although I hear from behavioral health orgs that we're still primary care centric in a lot of things we do, and I understand that. So partly it's because we're still doing patient-centered medical home, and it doesn't always apply fully to behavioral health settings. 2018 is when we had the kickoff. If you guys probably remember that, it was, I think, in April 2018. It was a big kickoff for the learning community. And that was kind of where the agenda was set of how we were going to move forward in the next 3 years of the MTP funding. We did some skill building workshops for motivational interviewing, quality improvement. It's when we had the behavioral health integration LAN, started in October. At the end of the year, I think I put it in the 2019, but at the end of the year, we started with an empanelment sprint, part of that patient-centered medical home. 2019 was the first full year of implementation. We heard a lot of organizations say that they didn't really get started on their change plan until 2019. There were some efforts going, but they really didn't dig their heels in until 2019. Okanogan County were transitioned IMC. In 2018 is when Chelan Douglas and Grant transitioned to IMC. We've been continuing to build on the patient-centered medical home, or the 10 building blocks we'll talk about a little later, with the sprints, empowerment, and team-based care, and then moving into the population health. And then 2020, we're really focusing on that population health land and our change plans in the population health mindset. So even though you're not participating in the land, it's okay. We're still having that focus as you look at the change plan itself and in moving metrics. And then 2021, it's basic, kind of move forward. We'll see where we want to go as a collaborative. We'll probably start planning this year of where we want to move and how we want to exist. The MTP funding ends at the end of 2021. So we will have decisions to make as a collaborative how we want to continue. I don't know what kind of funding or if we'll have funding to continue the learning community. But if we wanted to continue meeting, whether that's monthly, every other month, quarterly, to stay connected, we'll start to make those decisions, probably form work groups later this year. Individuals are wanting the charters. That's on the website. You're welcome to take a look at that. But I just wanted to run through, there was a shift from patient-centered medical home, very primary care centric, to including behavioral health, so it doesn't always seem that way. We were doing a lot of collaboration, I think, with the whole person care meetings, and we shifted into a leadership series, which took up a lot of our time during the WPCC meetings, so the shift as well.
Add something?
Sure.
So this is Linda. I would just add something that, because I remember very clearly in 2015, we knew that in 2014 legislation had passed in the Senate. It was Senate Bill 6312 that required all Medicaid contracts be fully integrated, I believe, by 2021. And because of that, we started kind of the Whole Person Care Collaborative in 2016, as Wendy said. And then January 9th of 2017 is when we heard from the federal government that the waiver had been accepted, and a little bit into 2017, the toolkit came out and we found out what the required projects were. And one of them was integration of behavioral health and primary care. So we were very lucky in North Central Washington because we sort of got a jump start by at least having what Wendy described set in place, and then we expanded it. So that's one of the real pluses that we've been very lucky about. And I'm on a panel for the state of reform with Elevate Health, which is Pierce County, Thursday in Seattle. And that's one of the things I will mention because we're kind of supposed to give an overview of things. So it's a lot of hard work, and I just want to thank all of you. Some days we wonder if we're moving forward or not, but we are. Thanks to all of you.
Thanks, Linda. For any of those of you that were here from the beginning, do you guys remember anything or anything different than what I've said, or you want to add to what I've said? I'm not sure who all was here in the beginning since I just started last year, or I guess year before last.
As a person who's been here since the beginning, I appreciate this. I did a similar timeline for our organization last year for our anniversary, and it really puts things in a succinct perspective. So thank you very much for doing that.
Thank you. So I just want to run through this quickly, not to belabor the point of patient-centered medical home. This was introduced in 2017 by Sheila Verschauer from Moses Lake Community Health. There was a 2-day retreat for the whole person care collaborative. A lot of the stakeholders were there talking about how they wanted, what they wanted to do with whole person care moving forward. And this concept was introduced, and this was the very beginning. This is what we've talked about that's very primary care centric. There are some overlapping, such as engaged leadership and quality improvement, but other things like empanelment doesn't necessarily fit in the mold of behavioral health. So we've kind of tried to adjust. I've talked about the 10 building blocks. I've put them up here because you can really see the overlap. Bodenheimer came out with this in 2012, I believe, and the change concepts, patient-centered medical home was kind of introduced in mid-2000s, I believe, but this structure of it, I think, came out 2010, 2011. very close to the time that the building blocks were showing the patient-centered medical home, both really representing that. I just always like the 10 building blocks more than I like the stair step, but I just wanted to see show you the overlap. There are the 4 change concepts: laying the foundation, building relationships, changing care delivery, reducing barriers to care. You'll see some of this overlap when we talk about the MEHAF, and then when we do the PCMHA this year for the primary care clinics, we'll be talking about those components. So trying to really tie that together. And if you remember this, we talked about this back in July, what we've done, the engaged leadership, where we're trying to do that here at the WPCC meetings. The data-driven is the quality improvement, empanelment sprint, the team-based care land that we did. We've done patient and family voice in QI, and we'll be doing this in the population health plan with those patient experience questions. We did a webinar on access, and then the population health plan. So you can kind of see where we're trying to hit on all the blocks. We're trying to fold in behavioral health as we're able to, and Kathy Rhymes, one of our consultants, is really helping us with that component of she keeps the pulse on behavioral health issues nationwide. So any questions, kind of a quick run through of that, of where we're at, kind of our foundation or bones that we're really working with as we move forward. And it's the structure of the change plan too. It's really inherently built into that. So as you've all submitted the change plan, it's really moving this population health forward. Any questions? Okay, we are going to do another poll, so you can get your phones out or on your computer. If you've already typed in what you have, all you have to do now is type in 5 words of what stood out from November's WPCC meeting. You don't have to do the number or anything. You can just type in and send it on that 2233 number. I'm sorry. Type in. Yes, I can. Sorry. There. Are you seeing it now? Let me get you set up so you can do it.
No, it's okay. Your history was great. That was good. Your history was great. Okay.
For those on the phone, you can go to that poll EV / North Central 418. It should come up there. Did not attend. Seemed like there was a need for clarification of WPCC goals and its focus. Clarifying the goals and focus. Thank you for your honesty. So clarifying the goals or the focus. Some didn't attend. Clarifying the purpose and direction of the WPCC. Discussed areas of opportunities. Some felt we lost the sense of purpose. Disconnection, transparency. We'll give it 20 more seconds and then I'll lock it down and we can open up for discussion. All right, I'm going to go ahead and lock it down. If you have more comments, you can put it in the chat box, and we can read those out as well. So that's basically what I took away too, is that we shifted focus and some thought we lost our purpose. And the purpose more was for collaboration, and felt that we really were not doing that as much as we could be doing that within these meetings. There was also notation that there's broad differences in the organizations, which sometimes makes it more difficult. There's small organizations, there's large organizations, there's organizations that have just started out in quality improvement, have never done it ever, and others who are very advanced with quality improvement. So in other things as well, not just quality improvement. So there's just a varying degree of the organizations that we have as part of our learning community. And some wanted to discuss the successes and challenges within the change plan during these meetings. So those are the things that I took out of the meeting. Kind of those sticking points of how what we can do better. So at the end of the meeting, Tessa said she wants to know what's working well. We should have that opportunity, express that. So we sent out the survey and asked, what is the purpose of the meeting? And these are, I just summed them up so it wasn't too much. On the email I sent out this morning has more dialogue on it, but didn't want to get stuck in the mud here in the meeting. But the purpose for individuals, they wanted to receive updates on WPCC events and timelines. They want to collaborate with other members. Some said they weren't sure what the purpose or mission is, that we've lost focus or we're struggling to get momentum. And some said that we're not aligned with the original goals of the WPCC. So that's what I got from that. What is the purpose of the meeting? Anyone have any comments or feedback on that? I want to add to that. Microphone, okay. Okay. I think the biggest thing I took out of this, what's working well, 5 individuals talked about collaboration, and I just summed them up, and someone said the meeting itself by merely existing already catalyzes change. And I think that's very true for, I've heard many organizations say that. Receiving updates on due dates, reporting requirements, upcoming grant opportunities and trainings. 3 individuals said that. 3 spoke about Rogers training. 3 said they enjoyed the high leadership engagement for those that attend. They appreciate the attendance by the MCOs. The management follow-up coordination and providing support to the organizations. And 1 person said not much. Yep. How many tickets? Let me double check that. I want to say 17 or 18. Can you go into SurveyMonkey, please? And why do you keep coming? Majority said because of the collaboration. So I recognize that we can collaborate more, and we will be working on that. We'll talk about that. Learning from others, their challenges and successes, networking and sharing concerns. Updates and timelines. Some come for the leadership series. Others come to hear trainings and grant opportunities. And it's required by the MOU. It is, so it's fair. I'm good.
That's not why I attend this thing.
15 people took. So what I really took out of this was and making sure that we understand what the focus is. And the focus is what the group wants. It shouldn't be my focus. It really should be the focus of what you want to get out, what's going to be the most valuable to you as a participant. And what I've heard, and correct me if I'm wrong, is collaboration, that we're focusing to change in this population health management. We're moving towards value-based payment, but it's that collaboration of learning what others are doing, their successes and their challenges, and working together. Did I miss the mark on it? And those on all those on, if you can chat in, please chat in. You've hit the mark, you've missed the mark. What other comments you may have? You saw some head nods that that's kind of where we're at. Yeah.
I put down collaboration. I think that's I was going to say I think that's the glue, but, you know, again, somebody mentioned transparency. I think there are some of us who, if it was not for the MOU/funding, there wouldn't be as many people. And I don't think that makes them evil or bad. They're just we are trying to prioritize where we invest very limited resources. And I don't think it's bad to admit that somebody's coming here because there's funding to help pay for them to come here.
I agree with you.
I would say, though, that that's not the main reason. It's the collaboration. Money just makes it easier to do.
I think you're right. And some, I understand, have many different hats. And so if it wasn't for the funding tied to it, you're right, they wouldn't be here, and I understand that. Any comments?
I think my position is actually funded by the money we get from, so I should be grateful. No, I actually enjoy coming to the meetings because I get to hear what other people have done that works, and it's like I can take some of that, twist it around if I have to, but I get a lot from sitting around these tables listening to your successes and challenges, because we don't have near the resources as most of the folks in this room. So I just want to thank you.
Melody said, I think we're missing some opportunities to have more power in our numbers to impact policy with the state. There was a long comment, and again, the comments are on the email that I sent this morning. You can go back and read, but it talks about as we learn the challenges that the organizations have, we're able to mobilize Linda and her impact with other ACH EDs to talk about the challenges and to be able to present those to the MCOs as well as Healthcare Authority, kind of fighting the fight from the ground. So we definitely hear challenges. A lot of times we hear it, Mariah and I hear it as practice facilitators when we're talking to organizations one-on-one. Other times we hear it within these meetings, and sometimes we hear it when we see individuals. Our kids have both had swim meets, both on the swim team, and we're sitting around the pool and we're talking about it, and we may hear it that way. Our staff and things get related back to each other within our staff. So various ways.
This is Deb, for those on the phone. One of the things, having been a part of this since the very beginning, what I've recognized and I've seen is our community partners have been very networked and collaborative like this for a long time. And I think because the CHIs were successful in the early days of the formation of this, that's that example. I am hopeful, I'll put it that way, that 2020 brings an opportunity, because community knows how to do this well, and healthcare hasn't. It's not that they don't know how to do it, they're busy and haven't had the opportunity like this, right? So I'm hopeful for the opportunity that the two of us can come together collectively as that true accountable community of health to really make change. And what I announced earlier, David, you missed my earlier announcement about an activity this weekend, but I think 2020 is also the year for empowering our community members who are most vulnerable, that we need to hear from to make the right changes. We have been, the ACH staff knows this term because they heard it at the same place I did. We have been too much of a drag and drop focus on, there's a project, let's drag it and drop it in. And what we drop in, what I've seen, what we drop in isn't always what our community, vulnerable community members need. without more participation from them. So I'm looking forward to even more collaboration.
Thanks, Deb. Anyone else? Doesn't look like there's more comments. So in light of that, one of the things that we are doing in 2020 is more peer sharing. It's what I talked about that was in the MOU. And so everyone will have the opportunity to present some QI project or effort that's tied to their change plan at a WPCC meeting or symposium. There is a sign up link right there. So you can decide which month you want to do your presentation. Go to that link and go ahead and choose the month you want starting in February. It's first come, first serve. So there are plenty of slots for everyone. And it's tied to your funding, so I would behoove you to go in and, but it is for the betterment of the learning community too. As Dave said, some people don't attend because there's not funded or it's going to be the same way with the peer sharing. Some people, it's hard to share, and I understand that. And maybe it's not you, but maybe it's someone within your organization that would want to share. So it doesn't always have to be you, although they'll probably delegate it to you. In light of that, let's talk. What are some of the successes in a QI effort that you undertook in 2019 that you're most proud of? And this goes for Deb and for the MCO as well. If you guys have done any kind of quality improvement or changes, so not just to the learning community. Does anyone want to open this up? All right.
Let's see, Dr. Butler, over there. I'm going to sit back from this microphone.
So you've all heard Dr. Butler over the past few years share at one of the summits, I think in 2017, about an effort to increase the number of certified medication-assisted treatment providers. We had, I don't know how many by 2015, 2017, but going into 2019, we had 15. We're up to 15. And by the end of 2019, we're at 19, and by April we'll have 20 certified math providers. So that's a good thing. In terms of quality metrics, Caroline has shared over time some of those healthcare authority metrics for our region. One of those being substance use disorder treatment penetration. In the last metrics we looked at, the 2017 HCA metrics, we were the 9th of 9 regions in performance, so the lowest region, obviously indicating the need to increase services for SUD. And so CVCH launched our outpatient and intensive outpatient SUD services in July. And we have 3 providers, about to hire 2 more. As of about 3 months ago, we're well over 200 encounters a month and on a sharp increase, so proud of that. And then third and finally, I'll share some of the other metrics actually for children's mental health that the state looks at include the mental health treatment penetration measure for 0 to 6, 7 to 12, and 7 to 11, and 12 to 17. And in March 2019, we by that time had realized that in pediatrics, our primary care providers just had not been utilizing our behavioral medicine providers at the level that we wanted. We needed to try something new. We fully embedded one of our BMed providers into our PEDS pod at 600 Orondo, and then in June did the same at Columbia Pediatrics 1 day a week each, and saw a significant increase in utilization of those BMed services in pediatrics. And so we actually very, very proud of that and have a plan to significantly increase BMed services in pediatrics in 2020, since that sort of as a pilot has gone really well.
Thanks, Blake.
As a federally qualified health center, CVCH is monitored by the federal government on 15 quality metrics, actually 16, but we only have to AIDS patients. So we kind of put that to the side. Two, we wanted to significantly improve on. One was the percent of children 2 years or younger that are fully vaccinated. This is kind of embarrassing to admit, but we were around 14% 4 years ago. Now we're over 41%. And, you know, obviously our goal is to be much higher than that. But working with our providers and their staff has made a big difference. The other thing is our high blood pressure, the percent of patients that are within a normal range. That's been a focus, and one of the things we did was we instituted a program that we call iPharm, spelled with a PH, and we have a pharmacist that's embedded in the primary care pods. We have the pharmacist huddle with the providers and the staff in the morning. They know which ones the patients they'll be likely to see. In particular, they meet with people who've been discharged from the hospital, and there's been a significant increase in that, approximately 10% in a year.
Thanks for sharing.
This is Mike Lopez with Granite Grade Services. I don't necessarily have, you know, metrics and things like that to share. I think the one thing that I'm particularly proud of for a community behavioral health agency is that the idea of quality improvement and being able to be more data driven in the behavioral health world, because we haven't historically had the quality metrics that, you know, physical health has had. So I do know that we've had some small projects like screening particular population for diabetes, which we've been really successful at. Hopefully for 2020, we'll be expanding that to more of our population. But just the idea of quality improvement has been something that I think is going to be very huge for us moving forward. So that's what I'd like to share.
Since this mic's on, I'll follow. As a community-based care coordination organization and a community-based, I can't, I get so tongue-tied. And as a community-based organization in general that started as a primarily grant-funded organization, community work is very different than healthcare work, and we all know that, right? We do collect data, but we collect outputs, not outcomes. So quality improvement is a challenge in a way, though we do have staff who have healthcare experience and we get it. So I would say currently in my world, in our world at Action Health Partners, we do more PDSAs, big quality improvement projects, because our changes have to be made so quick. Oh, this didn't work, we got to go to this. Oh, this didn't work, we got to go to this. Our experience for the last 6 years with the Health Home program is kind of one of those examples of the state started out, Courtney might be able to help me accurately say this, but the state started out with a dream that there would be 60% engagement rates in the Health Home program by year 2. We're at year 6 and we're barely at 26%. So through support from our state partners, they have worked on how are they redoing their quality improvement or metric measurement to deliver to CMS so we can improve those numbers. And it's not necessarily making on the ground change, it's really changing how the data is reported, right? So we do these rapid PDSAs all the time. I'm familiar with that from my old tobacco systems change work, right? My previous work was like what the Whole Person Care is doing on a large scale. I was doing it very specifically to one target, which was tobacco. So I think, again, I am the voice of community right now at this table, and what I see is community doesn't understand that outcome reporting. Is outputs. We have names of people that have participated in our programs where we need healthcare is so what? That people attended my diabetes self-management class, I can't tell you a darn thing about the reduction of A1Cs, unless, of course, I have a data sharing agreement with you that I say, here are the people that did it, that were your patients. You tell me what their outcomes were. We've worked in the last few years, several years, we've had contracts with Qualis Health, now Comagin, since 2013 to collect our data from our diabetes self-management workshops to plug into the statewide outcomes of how are these workshops helping, but I don't have that local data because the numbers are too small. And then we get in trouble because you got to suppress the names because the sample size is too small, right? So there's a whole lot of room. I get it, but just keep in mind that we're more PDSA rapid cycle than a big major project.
Tessa, Confluence. I speak about the suicide screening. So I'm going to speak about the suicide screening. We've had a lot of QI efforts in 2019 that we're proud of. I think the biggest one for me that was a real focus for myself was the PHQ in primary care at Confluence. And for a couple of years, we have been giving out the PHQ in our primary care locations and kind of at a 35% rate. So if you come in, 35% of the people are getting the PHQ. So in 2019, we made a real focused effort to increase that. And we went from 35% to 63%. In just a little bit more perspective, we have over 27,000 primary care visits in 1 month at Confluence. So 63% is huge success for us. It's a huge undertaking in all of our different sites and all of our different departments to have to implement this. So we're not stopping. We're going to continue to go. We find it very important. So that one's exciting. The other one that I'll mention around suicide screening that I'm really proud of is the collaboration and partnership around this table. Implement the PHQ to all incoming 9th graders at Wenatchee High School. And I think every local organization, behavioral health, CVCH, Children's Home Society, Catholic Charities was all involved in that effort. And there was 580 incoming freshmen, and it was huge. It was a huge effort, and that happened in September. So I'm really proud of that too. And then
on the behavioral health side, I think our thing I'm most proud of is incorporating more primary care principles into behavioral health. Blood pressure checks for people, seeing prescribers, metabolic monitoring for patients on atypical antipsychotics. We've made quite a bit of improvement in regard to both of those. And they're both really helpful in terms of making sure people are getting the screening and care they need.
And both of those two that Craig mentioned were because of LANCE.
Because of LANCE, yeah.
That we were involved in.
And so now we're in the position where we're actually adding 2 MA staff to increase the amount of those we can do for our patients, because it's been really limited by our 2 nursing staff. And started doing two MAs with a whole new workflow to hopefully get 100% this year.
And this is for our outpatient behavioral health.
That's great. Thank you for sharing. Courtney?
We have to do a round robin. So this is Courtney Ward with AmeriGroup. I would say for this specific region, QI has been, we've been in startup mode for most of the state for integrated managed care, with most recently the final 3 regions going live as of last week. So what's been great about this region is because of the go live of 2018, we have been able to kind of kickstart a couple of QI efforts. I would say probably the most notable are we have a project with the University of Washington and working with CVCH and looking at Catholic Charities down in Greater Columbia and hopefully maybe Children's Home Society of improving evidence-based practices for children's mental health services. We had a state priority or state quota to meet as a BHO, and in IMC land that has fallen off dramatically, and we will, as MCOs, have to kick that back up to what that quota is supposed to be for each region. And because the billing system has changed as well, the service encounter reporting instructions has changed, there's been a drop in education to the providers in regards to how those EBPs can be received through a claim. So that's been a great QI effort. Most just recently been working very closely with Blake actually to get this rolling, of how we look at EBPs, what trainings are needed in the region for providers for EBP services, and then 2, how do we get back into getting those adequately reported to the MCOs and captured so we can report those to the state. I have another one and it just lapsed. Oh, I would say that the other one we're doing is for the evidence-based practice for SBIRT. So looking more at, a wraparound service that we can do that's mostly incorporated in the physical health space, but, leading to a triage or linkage to behavioral health services. So just another evidence-based practice that we're trying to get rolling and more robust for integrated managed care. Those are specific to AmeriGroup. I think overall as MCOs, just looking at probably the one most notable for this region is how we're trying to really monitor the crisis system, specifically Parkside, ensure it stays stable and funded and open, and that the right services are provided within that region. And so I think collectively as MCOs, that's probably the most targeted one that we're looking at.
Thank you.
Holly, Children's Home Society. So when I hear the number of 27,000 in a month, we're at under 10,000 in a year. So you can maybe take a look at the scale of what we're working on. So we work with really intense cases. So we have the same people coming in and seeing different people. So, I could say that QI, we've done these little things that have moved the dial for overall health, but the thing that has really improved for us is that the language around PDSA. So if I send out a meeting and say, hey, we're gonna have a PDSA, people show up and they know what we're gonna do. So that's kind of a shift culturally for us. So the idea that people are now beginning to think about how we can improve, and that improvement is a responsibility of every individual since there's so few individuals, that's probably the biggest story for us right now.
What I'll say to that is that when you look at even just productivity within the behavioral health world, because when you start talking about productivity, people get, well, we're not doing enough or whatever. And it's like, well, if I can introduce it as a PDSA and improvement and things like that and reaching more people, have a lot more success, getting people to show up to the table. That's exactly what I was speaking to, is just the idea of quality improvement has been huge for us. And it's going to be huge for us. So.
I think it's great. I don't think it matters how big or how small you are. It's quality improvement within your own organization, and how do you improve for your patients. And you may have way less patients than Confluence, but you still have a set of patients, and how are you improving what you're doing for them? So the fact that you're starting that QI, and I think that's fantastic.
Well, I was blissfully ignorant of quality improvement, change plans, and all this stuff March of last year. Then I changed positions, and I am really proud of the way we have taken the PHQ-9, embedded it in our assessment, in our reactivation appointments and transfer appointments, so that everyone walking through our door is being screened with a PHQ-9. We have the CCRS. If it's tripped, then we follow that. The main thing we're working on now, well, we'd be doing the diabetes fun stuff coming up, and the patient voice, and let's see what else. Oh, trying to increase referrals for clients who are not imminently suicidal, but are showing moderately severe or severe depression. Clinicians have just been kind of giving them the PHQ-9 over and over again rather than referring, and I'm like trying to push toward the referral.
Thanks,
Thank
Paul.
you.
And we also have a comment from Melody in the chat. So Family Health Centers has completely revamped the Quality Improvement Committee and QI efforts to include more provider participation. They implemented an online PDSA tool that has resulted in organization-wide participation. And one team-based care improvement is that they are now utilizing pharmacists as part of the primary care team with chronic condition patients. So this has been greatly appreciated by providers, and they feel it's a big help in patient care.
Thanks, Melody.
Thank you for sharing, Melody.
Who else on the phone do we have?
This is Christina, Columbia Basin Family Medicine. One of our QIs was working on our opioid use agreements and policies. In 2019, we got updated and signed contracts from all of our patients that were on long-term opioids. And we went from 57% to 91% compliance with follow-up visits for those patients.
Great. Who else? I'm looking at my paper. I'm going to start calling on people.
Oh my goodness. This is Jeannie from Catholic Charities. Our quality improvements, we've done like a lot of PDSAs this last year, and we have a monthly QI meeting now with our Yakima and Tri-Cities offices, which has been really helpful as far as implementing some changes, since it not only affects us here in Wenatchee, but over the region. So that's been a really good improvement. I would say I would just kind of echo what he was saying earlier, just that looking at quality improvement in all has been a switch. I think one of the challenges that we've had is that other systems like Confluence or CVCH have really advanced electronic health records, which we don't have access to, and so some of these have been a little bit bumpier starts. So those are my 2 cents.
Thanks, Jamie. I'm looking at my list.
Hi, this is Anna at Cooley Medical Center.
Go ahead.
One of the things that we want to talk about are probably one of our, we have a lot of successes in our QI over the last year, but one of the main ones that we're really proud of is the percentage of Medicaid patients that are assigned to a PCP, or panel progress that we made over the last year. For the Q3 reporting, we had 99.75% that were impaneled. That was a huge progress we've made throughout the last year. It took a whole team effort, and it was really helpful for us to do the empanelment plan. That kind of gave us kind of a jump start to where we need to start at and kind of build our processes from there. Thank you.
Thank you. So I have Mid Valley and Okanagan Behavioral Health and Lake Chelan.
This is Tracy and Becky at Mid Valley Clinic. And, you know, Becky and I are literally sitting here going over our metrics, and, you know, we do more than just what the change plan, what we put in the change plan. And so internally, we've come up with multiple QI projects related to diabetes, access to care, transitional care management. And, you know, for us, our providers are doing an amazing job, and we've seen improvement, even with us in the middle of all this transitioning to a new EMR. And so additionally, one of the biggest things that I'm proud of is we have been trying to work on our integrated behavioral health into the clinic, and having Leslie join the practice has been a huge asset to not only us, but to our patients and our community as well. So we feel like we ended the year on a really high note, feeling really good about the quality of care that we're not only providing but how it's meaningful and impactful at the same time. We're not just measuring things to measure things. We're measuring things to improve upon it and make more impactful decisions downstream.
And then I would, add that we're very excited about 2020 because we're planning on finally implemented a fully integrated approach to substance use disorders and such. And so we hope to launch that within the first quarter of 2020.
Very excited about what the new year's going to bring for us here.
We look forward to hearing from you guys. Thank you. Lisa has having trouble with her mic, so she was typing.
Okay, Lisa just shared that OBHC continues to work on increased access to care by improving walk-in model for services. Over the past month, they have drastically improved capacity for individuals to walk in and receive same-day services for both mental health and SUD services. Access has been a biggest criticism by stakeholders and clients, and we are now getting compliments from both on how nice it is to come to OBHC and be able to be seen by a provider so quickly. Working on pulling statistics now, so they don't have any actual numbers yet.
Great. I have Moses Lake Community Health and Molina and Lake Chelan. And Cascade Medical. Jorge, do you want to share anything from Molina?
Thank you, Wendy. I think what Courtney said pretty much summarizes what we are doing in the different MCOs, the common approach. I think the transition to integrated managed care has been a little bit of a challenge in implementing quality programs and quality metrics because providers are new and the plans are new to managing behavioral health. So we're kind of in the middle of that yet. We try to follow a very methodological approach to this, so we're still in trying to meet let's say the demands of the healthcare authority in quality. We Molina scored first place again in quality metrics from the state in the Apple Health Card, but I don't think that we're ready to say that we have yet the great program because for behavioral health integration because we're just starting to develop those. So I think what we can do, and this is part of the conversation that we were having, is how MCOs can communicate this throughout the year, and for these peer groups that you're planning on having, if we the MCOs can come forward when we have something really valuable to share.
Thank you.
So it's also a question, Wendy, because it's do you think that we should start coming forward with registering for presenting when we have something to share this year with the MCOs, I mean?
I'm sure our learning community would appreciate that. I've heard from a few, and those who are on the phone or in the room, I see some head shaking, would appreciate hearing from the MCOs. When you guys have something, if you let me know.
Okay, will do.
That
Thank
would be
you.
great. Do we still have Whitney out there, or Gail, or Heather? You see any of them on there? Okay. I'm not sure how I'm letting you off the hook right now. But I guess I will. Maybe because you're all new. No, Heather hasn't been there very long, and Whitney just took over that position, and Lake Chelan's gone through a lot of change this last year, so I'll give Gail a break. Or if you want to type in, that would be great.
You have time, I can show a couple of the opioid use disorder dashboard stuff that shows our recent but in terms of capacity.
Sure. So if I stop share, can you screen share?
Yeah.
This is riffing off of what Blake was mentioning. Let me just go to my Zoom, share the screen. So this is a dashboard that the state of Washington put together. And for those of you on the phone, you should be seeing OUD treatment for Medicaid population dashboard on the screen right now. There's a number of measures And right now I have selected all ACHs so you can see how North Central compares to the rest of the ACHs. The current measure that I've selected is the proportion of active buprenorphine waivered providers. And so obviously if it's a dark blue bar, it's good because it means it's above the statewide average. And you can see that for the North Central region, which is the 5th one down here, we have the highest proportion of waivered providers for our region compared to all other ACHs. There's also a measure that shows the number of waivered providers per 1,000 Medicaid. Of course, this is all Medicaid specific because this is coming from the Medicaid transformation dashboards, but per 1,000 Medicaid enrollees. And again, you can see that North Central ACH is doing really well, especially with nurse practitioners and physician's assistants. There are also some treatment measures. So in terms of treatment initiation, so I'm just gonna pull up one of them just as an example here. And again, you can see that North Central is doing well. So this is about initiation of OUD treatment with MAT. And you can kind of see the trends over time. If you select, I'll put this link in the chat box if anybody wants to use this, but I think like globally, I know everyone's working on their change plans at the micro level. This is a chance to zoom out and, you know, we can't say that causally everything you're doing is impacting this, but like clearly there's a correlation. And I think it shows that our region is doing some really great work in terms of increasing that capacity. So remember this dashboard because I think when you report back to your funders, I think this is one of those data sources that you could use as an indicator that you're contributing to meaningful capacity building. So just wanted to kind of point that out. Absolutely. If I put it in the chat box right now, is that good enough? Or do you also want it via email? What works best? Okay, Wendy will send it.
Yes, I will be sending that MAT waiver training flyer, and I just made my note to put that in there. So you can get it on your email.
Congratulations to our region. I just wanted to make sure to point that out. Thanks for bringing it up. Like,
I will also say that the BHI land, the empanelment sprint, and the team-based care land were all three mentioned as catalysts for QI projects that found successes. So as we're doing these learning activities, it's helped our organizations. And so I just know from talking to organizations, those were what were mentioned, that those organizations mentioned it now, but I know that a lot of improvements been made from those, not just from the four we heard from. Thank you. Now to figure out how to share again. All right. There we go. I found that very exciting. Did you guys? Hearing from each? I can't wait for every month hearing like more in-depth details of really sharing successes and challenges. I think it's very helpful when we hear challenges because one, it helps those organizations who are thinking about going through it or are currently going through it not to feel so alone when they're facing the same challenges because we all do. But also to hear the successes that there is a light at the end of the tunnel. Our next steps as WPCC, there was a series proposed on social determinants of health that we talked about back in November. It would start off in February as kind of just setting the stage, foundation, sharing business case tools, and doing some peer sharing about what you are doing for organizations, what type of screenings are you using, did you come up with your own questions, are you using a specific tool, those types of things. Then in March, have a guest speaker to come talk about some exemplar programs. Roger spoke of one in Oregon, which is very similar to what we are, of what they've done and how we as a collaborative, as a region, could do something very similar. Not just as a learning community, but as Deb talked about, is bringing in the other stakeholders, because healthcare can't address social determinants of health alone, and nor should they. should be a community effort and how we could do that. And then the April, of course, is that design session of what you might be able to do together. So here are some of the sample case, business case tools he's talked about that he would share. And the ask for the homework is there, kind of what we were talked about. But I wanted to hear from the group, what do you want to collaborate on next? So let me activate this one. And I've added the social determinants of health. If you want to talk about a different specific disease or condition, if you want to collaborate on that. If you want to continue the leadership series, which Roger had proposed, joy in work, strategic management, cascading plans, kind of what we were doing. Or you don't want any formal topic at all, or other. If you say other, we'll ask you to explain so I know where your thought process is. So if you'd participate in that, we'll get our direction.
I only get one choice. Yes. I know that's what I was saying.
Yes, what is your top choice? Sorry. I like this polling. I just wish it would tell me how many participated so I know how many we're waiting for or if everyone's participated. All right, let's do 10 more seconds. Seemed like an easy one, I guess. Easy and type it in the letter, not easy on choosing. But it looks like social determinants of health is what we'll start focusing on. Okay, I'm gonna lock it out at 69%. So here is your homework, because you all said you wanted homework. Doesn't that sound like fun? You're back in school again. It's very easy. Are you screening for social determinants of health? If yes, how and with what tools? I think Roger's on the phone, so he knows to keep preparing. It's going to be very interesting to see as a region we're screening for social determinants, what our target looks like. We can talk about housing, but how are we screening for housing? There's so many different questions you can ask.
So this is Deb. I want to interject. I know that there's a lot of conversation about the hub. There's going to be some very strategic conversations this next month about the hub and moving forward. But the one thing that I want everyone to know, our team is very small and we do the best we can. But we have created for our referral partner packet that we've been working with the Whole Person Care staff, we have created a one-pager social determinant screening tool that we found at the Communities Joined in Action, which is the National Hub Conference that we attended in April. And I would highly encourage that I'll make sure that you guys get it so we can share it out with everybody. I think this collaborative is a good way to get that tool out to everyone, but I would encourage folks to look at it so we're not duplicating some of the efforts, right? Part of my concern is having seen a few of these maybe the change plan, the social determinant screening, some of them are basic, some of them are huge. Some of them are so huge that primary care providers are actually doing the assessment that we send community health workers out to do on the client when we engage them for the hub. I can tell you that our internal care coordinators who have been doing Health Home for a long time say this about PHQ-9. We do it too much. Every place our clients go, they are getting a PHQ-9. My care coordinators personally say, we quit answering the questions honestly because we know how to get the things moving forward. If my staff is saying that about when they go to their personal provider, they're avoiding the PHQ-9 by answering the way they know they should be answering, that's a serious thing. And my concern is if we are over screening for social determinants, building trusting relationships with our folks. So how can we partner and collaborate better and closer on that social determinant screening tool? So it will be easy for our primary care and behavioral health partners to know, oh my gosh, this person is probably hub eligible, let's send them on. And you don't have to do the work that there is funding for us to do. So to me, that's a big important step for this next year, depending on what we decide to do about the hub. But even regardless of what we do about the hub, Health Home is still the highest utilizers in the care coordination program, that there are already that social determinant service work happening in the community for the Health Home eligible. So regardless of what we do with the rising risk population, high risk is already getting services. So how do we collaborate more and increase engagement in community-based care coordination, period, regardless of what program it is?
So I've got a question. Anybody wants to do triple and quadruple redundancy, and we've all gone to providers, had to give the same information over and over. So I get that, but how is it that we are breaking down a trusting relationship with patients if they get asked to fill this out multiple times?
Well, that's a good question, because my ACH partners know that I've spent a ton of time digging into this. Relationship is in healthcare, absolutely. Patient relationship with providers is a vitally important component of healthcare delivery. And community-based work is 100% relational, and I say that because there is no expectation of a payment from the client for the service. So I'm not saying that you're breaking down the relationship, but what I'm saying is if so many of us are asking about housing over and over and over and over and over again, my question is, and I don't have the answer, but my question is, are people going to quit answering that question truthfully? Because everybody asks them that. And I think Barry has a really good way of saying it, and I can't probably repeat his words exactly, but especially the Medicaid population, we are targeting them for all of this work, right? So they're getting bombarded with the same questions over and over and over again. I have a quote that I've started sharing that is this: relationship builds at the speed of trust, and social change builds at the speed of relationship. It takes time to build those relationships, and my concern is if we're just asking these same questions over and over and over again, are we delaying the opportunity for building those relationships? And I don't know, David, if I've answered your question correctly, but that's my perspective from the community side.
Thanks, Deb. I think it's a very valid point and something that we can definitely discuss. So just as we're asking if you bring your social determinants health screening as well to the next meeting so we can have that conversation and see what is the best route when we're talking about a region. How can we best serve our patients beyond the screening? Because the screening is one thing, but moving beyond that, when there is a positive screen, a positive assessment, or an identified need, I should say, what are we doing about it and what can we do about it? Some things we can help. There's some things, I'll say housing. We know there's a housing crisis. There's probably not much we can do, but let's look at what we can work on together. So I think that will be a really good thing that we can work on as a collaborative and move our region forward. Any questions? Anyone on the phone? All right. Anything else for the good of the order that anyone wants to talk about? Share? Roger shared this will all be a part of the dialogue in February. A lot of great work going on already to build on and many lessons to learn from each other. Exactly. So here's our last poll. For those of you in the room, you have it in front of you because you can't do this on your mobile, but for those online, it's actually a survey for the meeting, just for feedback. You can go to pollev.com, I think. Make sure it's activated, not locked. You may have to come out and go back in. If you would fill that out so we have some feedback for this meeting and moving forward, how we can do things better. Thank you. Thank you for coming. Thank you for participating. Thank you for sharing your voice.
That's a great feedback.